Thank you, Jeremy.
Good morning, everyone.
Morning, Chair.
I went to that Microsoft Teams meeting. I was like, hey, there's nobody here. I went and looked at the calendar. All these different Zoom meetings and stuff going on. So
It can be confusing.
yes.
We are not quite at quorum. I'll let you know when we are.
Yeah, we'll just chit chat. I don't remember, how do you change your name?
Usually you do it on the dots, and I was trying to do it this morning just to put, since I logged on, just to put what city I'm from, but I couldn't figure it out. So
Yeah, usually it has that option in here where you're so I could put it as a Chandler, but I guess it will be my business for this meeting.
Morning, Councilmember Condi. Thank you for being here.
Good morning. Thank you.
Good morning.
Good morning.
Vice Chair Dunn, is Vice Chair Dunn on?
yeah, I'm here. It's actually Duff. I'll just,
Oh,
now that you're used to calling me Dunn, I'm just going to correct you now. I was just going to wait a little longer till it really got in your head. Then
I'm so sorry. You
No.
want to take it up? I actually
just
our former mayor, Boyd Dunn, I literally have a message into him this morning about another issue. And anyway, that's why it's in my brain. Anyway, I apologize.
no problem.
Embarrass now before we get started. It's good though. You called me out. But I wanted to thank you for the amazing Veterans Parade that you guys put on. And that, and the Captain White, your Grand Marshal. Oh my gosh, what a story.
Yeah, 100 years old and part of the
Unbelievable.
Schindler's List. The stories he had to tell is tremendous. Thank you for participating in it.
I was in awe sitting there. I just really was blown away. And how sharp he was at 100 years old. And I wish I had that much mental clarity.
Right now.
Yeah, half his age. It was incredible. I can only imagine the stories that he has to share, but it was great to honor him and the rest of the veterans at your parade. Thank you for letting Chandler be a part of it.
Yeah, thank you for being part of it. It was a great parade.
Great. How are we looking on quorum? We ready to go?
We are not quite there yet. We are one short. I'm going to email everybody just as a reminder.
All right. Start text messaging and we can all get.
We are one shy of quorum, Chair, so hopefully we'll have someone else join here in just a moment.
All right.
Who's on the committee that we can text real quick that I don't have a lot of people on my text.
We had confirmations from Vice Mayor of Scottsdale, Betty Janik,
Okay.
Councilmember Wally Campbell of Goodyear,
I wonder if I have Wally's number in my phone.
and Councilmember Bill Patana from City of Peoria. Okay, Chair, at this point, we can move forward with one of our presentations if you would like. And when we have quorum, we can go back and formally begin the meeting and do approval of minutes, et cetera. Or we can just give it another minute or two and see if anybody else is able to join us for quorum.
No, I think we want to be, thank you. I think we want to be sensitive to everyone's time here, and we'll come back and approve the minutes, because the first couple of presentations are for information and discussion mostly, and so there's really no action items that we need to take with quorum. So let's go ahead and move forward. Just everyone, welcome this morning. I appreciate you being here. And just as a reminder, if you are going to speak, please turn on your mics and let everybody know who you are. And since this is a virtual meeting, a roll call vote will be taken for each action item on the agenda as we get to if we get to quorum. So and phone only attendees will need to press *6 to unmute themselves. And so we'll now begin the meeting. We'll come back and do a roll call, Kelly. Yeah, we'll come back and do a roll call if we get to quorum. So why don't we go ahead and kick off crisis intervention team model, which is item number 4 on our agenda, and will be presented by Mesa Police Detective Amanda Stamps. Amanda, hopefully you're ready. And this is on the agenda for information and discussions. Any questions or comments before we get started? Okay, Officer Stamps, please take it away.
Morning, everybody. I apologize. I have a weird glow. I have a light behind my head that you can't see.
You
I'm
have
not
an aura.
glowing.
You have an aura.
I do, apparently. I wish it were bluer. Thank you all for letting me come present today. I really appreciate getting out there to talk about what we do in Mesa. I've been doing it now for a full time for about 6 years, which is unique in and of itself. We started all of our initiatives about 2015-ish, and I was the first person that then Chief Mesa pulled over to run full-time programs. So we're going to start with some numbers because what I have learned over the years is that numbers matter, data matters. So if you can go to my second slide, please. I recognize that not everybody is in Mesa, but I will tell you that across the board per capita, our cities are kind of looking at the same thing. And the point of this slide is if you look at the graph there, we had a steady increase over the years of these calls, and these calls are very specific calls. They're suicide attempts. There's something that we call pickup orders, where we go out and basically detain somebody for a mental health evaluation. And then we have an overall generic code that is 918 that we use for everything mental health that is not criminal related. What is important about those numbers, and I will tell you that the decrease that you see in 2020 is going to be explained. It actually is based on one of our programs. But the point of this slide is if you look at our total calls down there at the bottom with Mesa, almost 300,000 calls. And you look at 2019, the corresponding year, it's only 7,000 calls. And in the grand scheme of calls for service, that's not a huge percentage. But what I will tell you is that anecdotally, and there's no way to track this, but just from my experience and working for 23 years now as a police officer, then the last 5 years or so, our calls are anywhere from 60 to 80% mental health related. We can't track them that way. We don't track, we track assaults, we track disturbances. We don't track people's mental health status. So it really is hard for us to have a definite way to catch these calls. And you're going to see over the programs that we created that we really have to focus on all of the intercepts and all of the various places that we can possibly keep people from having contact with law enforcement or having the best experience when we have contact with law enforcement. You can go on to the next slide, please. And these are just numbers for you in case you're not aware of how many people use our crisis system. So this is Maricopa County specific. These are the last 12 months. The top left is total crisis calls that come into Solari, so the Maricopa County crisis line. We had a little dip in 2020, and then they are starting to skyrocket in 2021. And so you see, on average, it's about 20,000 calls into our crisis system every month in Maricopa County. And then down there at the bottom are the crisis teams. So that is when they send 2-person teams out to houses. There's about 2,000 on average recently that have been going out. I will tell you, out of that 2,000 calls, about 350 are law enforcement specific, and they're county-wide. Next slide, please. So I show you that because what I have found working with my city and other government entities over the last 6 years or so is that the public typically wants zero response to mental health from law enforcement. I will tell you, in law enforcement, we want zero mental health response too. That's something that we're not opposed to. But the problem that you saw in those numbers is when somebody calls 911, it is really hard for us to absolutely say, number one, that it's mental health related or behavioral health related, and number two, that it's safe enough to transfer over to a different call. So I'm going to talk about 3 different sections that we have in Mesa. One is our starts at before our 911 or at our 911 services, then what we do for our patrol officers who are taking most of the calls, and then our specialty response, which is that crisis response team. Next slide. One of probably the proudest things that I've been involved in with the city and the department has been 911 diversion. We actually started this back in October of 2019. I will tell you, if a lot of your cities are looking at this, and luckily we have done a ton of legwork at this point. We are happy to share this project took 10 years for us to get off the ground. Because there was a whole lot of talk about liability and legalities and how do we do this and what does it look like when we do this. And it came with approval from internally in the police department. It came from approval within our city. So we had to talk to a lot of people to make this happen. So in 2019, when we started this, we saw that steady increase. So you can see the end of 2019 through 2020, 2020, we averaged over 100 of these. And that's where you saw that decrease in our calls for service in 2020 was a direct result of this diversion system. So this system transfers it straight to the crisis line. And these are people, they're professionals, they're mental health professionals, they're crisis specialists, they're the people that know how to do this and that we trust to do this. So we sat down with them this year, and what we did was hired one of them to come sit in our communications place. And we also changed our policies to match this because we, in the police department specifically, we're really heavy on our policies. And until you change policies, cops are not going to stop doing what the policy says. The dispatchers are very careful about matching policy. So we had to change our policy. And we did that based on what CRN/Solari told us to do. And you can just see in the few months since they've taken over, we're above 150 every single month. And last month we were at 188. That is, I think, like a 60% increase just in the first 4 months that they're with us. So we're super hopeful that this is going to continue to increase. We don't believe, obviously, this is going to be 100% all the calls that we take. I will tell you about 14% of the suicide attempt calls that come into us have weapons involved. So we know those are never going to transfer over. But this is kind of the biggest thing that we have done to get people the help they need. Because that is really the whole point of any of these diversions. It's not that we don't want to do it. It's not that cops can't do it. Our statistics actually show that we're super good at this stuff. We've gotten really, over the last decade, I told you I've been doing it 23 years. Over the last decade, our training and our officers have gotten very good at handling mental health calls. And it shows in the lack of use of force. It shows in the people getting transportation to where they need to get. But the reality of it is they're still not getting mental health help. And that's what this whole point is. Next slide, please. And Kelly, should I pause for questions?
Mr. Chair and members of the committee, Amanda, we will take questions at the end if that works for
Okay,
you.
I just want to make sure because I don't usually pause very well.
Thank you.
Okay. So this is what our on-scene response looks like. Those calls that are getting through that we can't transfer out, we're always going to have this because like I said, you know, we get domestic calls, we get disturbances, we get trespassing, we get a lot of different calls that start out looking like they're criminal calls that turn into some kind of behavioral health call. So in 2016 and going forward, 100% of our officers have training in basic crisis intervention. In fact, the Arizona Police Officer Standard and Training took the training that we do in our basic academy and made it required statewide. So we've been doing that for years now. We also have something called CIT training. So it stands for Crisis Intervention Team. It's not a team, it's a team concept, just to make that clear. The whole idea behind CIT is that we create this giant world where officers, providers, family members, peers, everybody interacts together to divert people out of the criminal justice system. So it's an entire concept. In fact, I'm teaching it right this week. I had to come out of the classroom to speak with you guys. We've got about 30 people learning it this week over here in Mesa. So nationally speaking, the CIT standard is 20% of your patrol officers have this training. And we're hoping that that is enough to hit when we need that the response. Obviously, it's not going to be 100%, but it is specifically in our policy on certain calls to ask for the CIT trained officers. Actually, this week, we're going to go over 30%, which I'm excited about. Some of your other cities, just for reference, I think Scottsdale has between 40 and 50%. Chandler, Gilbert all has upwards of 30%. The West Valleys are doing this. This is done Maricopa County wide. We do one class a month, and we spread it out across the valley. So all of your cities are doing this training. What we really want to make sure we're doing is that jail diversion or that diversion over to behavioral health services. And in just Mesa alone, I will tell you that we take people to community bridges over 300 times a month. So that's a lot of transports over to community bridges. And that is a huge increase over years that we have developed. And this is a variety of different types of transport. Some of it's for substance use. Some of it is an involuntary where the person really doesn't want help, but by statute, we're required to take them in. Some of them really just want us to drop them off to get help. So having CBI in our city was a game changer for us. At the facility on Javelina that opened up for us was a really big deal. It changed what we could do because we used to have to drive into Phoenix for a lot of that. In the West Valley, they have their own facility like CBI, and then in the central Phoenix area, there's the UPC for connections. I will say that all of our officers have some kind of response in autism or some kind of training in autism response. And from what we have seen is there's very insignificant use of force over the last 5 years. I specifically look at calls that involve suicidal people. And I can tell you that it's 0.0, it's a point percentage for use of force. I will say that I don't know that it's dropped over the last 5 years. I can't say that because I didn't keep data. I started keeping data 5 years ago. So, but in my career, it's never really been significant, but we can really show that now it is insignificant. Okay, next slide. And then lastly is the specialty response. I think there's a little bit of a misconception that these specialty teams were created to take 911 calls. I want to make sure that you guys know that very few agencies can do that. In Mesa, we decided to basically go for the low hanging fruit. Per state law, there are certain things that we have to do as law enforcement officers, and one of them is to take people in for involuntary evaluations. So when we looked at the numbers, in a city as large as ours is, and the thousands of behavioral health calls that come out, we decided to focus on these pickup orders, is what we call them. So that is where the mental health support team came from. In Mesa, we also have something called the Residence Assistance Program. It basically identifies somebody at the house that may have some type of disability. So it gives officers a heads up when they're going on to calls. We have found over the years that the more we know before we get there, the better the results are. I will say that a lot of your cities have this. I know Scottsdale does, Chandler does, Phoenix is working on it. I can't speak for West Valley, but a lot of cities have some type of identification program. One thing that I'm most proud of is called the Be Safe Autism Training. We just certified 9 people here in Mesa to do kind of like the train the trainer to put it on. I encourage you to look it up. It's called Be Safe, the movie. It is an autism training that pairs officers and individuals with autism and disabilities together and teaches them how to interact. So it is literally a one-to-one training with individuals with disabilities on how to be safe if they're ever interacting with law enforcement or first responders. So it is an amazing training. It is evidence-based. Hopefully it's gonna grow here. A lot of cities, Chandler has certified people, Scottsdale has certified people. I'm pretty sure Tempe does, Phoenix does, Glendale does. So we're trying to make it as big of a training. The unique thing about that is, I will tell you in law enforcement, people come to us all the time and tell us to get training and this, that, and the other. You know, anytime there's a poor interaction, people always say that the cops need to be trained, the officers need to be trained. And I don't disagree with that. But what's unique about the Be Safe training is the autism community said, we also need to be trained. Like, we need this training too. So it is very much them reaching out to us saying, we're going to do our part to make sure that these interactions work. And that's what makes it work. Also, we have the medical alert programs across Maricopa County, and that is the bracelet that you all know. It's nothing new. The only thing is that we have scholarship programs in Mesa, Scottsdale, Phoenix, and Maricopa County Sheriff's Department where we can get jewelry for free. So people can actually just fill it out and we get it to them for free. When we created all of our different programs, we also created a mental health advisory board that contains members of our community, the providers in the community, and every time we have policy changes or training changes or whatnot, we bring it to our advisory board. Right, it started as Mesa only, but right now I will tell you that we invite other East Valley cities just because we tend to work with the same people. So it is a very key to involve the community in the decisions you're making in these programs. And then what makes everything that you're seeing work is the relationships that we have with all of the providers, with CBI, Jeremy, Eric, I know those guys. We have each other's cell phones. You know, if something is not working, we communicate with each other. All of the clinics here in Mesa, and there's clinics in your other cities, the behavioral health clinics, we communicate with them directly. We even have a contact with the Regional Behavioral Health Authority, who is directly connected to access when it comes to funding. So all of that works because of the connections we have built with each other. Okay, next slide. And I'm just going to talk about our mental health support team. It used to be called the crisis response team, which I think is what the program said. I will tell you, we switched last month to mental health support team. And that is a direct result of the programs we're creating, because there are already community-based crisis teams, and we don't want people confused about who's got a crisis team and who they're calling for crisis teams. And as I told you, our mental health support team is not connected to 911 calls. So we want people to understand, if they call 911, that we're probably going to send a community-based crisis team and not a police-based crisis team. So that was the reason for the change. We've been around since 2016. I came on in 2015. We have grown. We started with 4 field detectives. Now we have 8 field detectives. The CIT program coordinator, which is me. I do all the training, the community outreach, the provider, the policies, all of that stuff. I also manage a federal grant. So I do all of the background stuff. And then we have a sergeant. We now have 2 licensed clinicians through Crisis Prep and Recovery. They are both grant funded. They will be with us for a few years. Their primary job is to follow up with the high needs people. So when the officers call and say, hey, this person's called us 5 or 6 times, you know, because they think somebody's in their attic or whatnot, my clinicians take over at that point, and we start doing background, and then we eventually follow up with the individuals. I already discussed this, but the primary job of the pickup orders are the detectives are those pickup orders, and those are state mandated. So a lot of times when when cities talk about taking my detectives and making them respond to 911 calls, what I like to explain is if we don't have our detectives doing these pickup orders, they really just go back to patrol. So we're really swapping one call for the other. And the thing we know about the pickup orders is this person has a known mental health issue, and it is in a crisis. It's to a crisis to the point to where a doctor or a judge feels they need an evaluation. So we take our more trained officers to handle the higher risk calls, and that's why we use them for pickup orders. Most of our job that the mental health support team does is state mandated. The 2 things that the state says that we have to do are these pickup orders, and then we can also force somebody ourselves in for an evaluation under certain circumstances. And then lastly, we help patrol as much as we can. There's 8 of us. And some weeks like this week when we're running this 40-hour school, some of us are not available, but we do our best to always be available for questions and to help when patrol officers need it. We like to divert back to the officers with the CIT training, but even then, sometimes they're either not available or they just have questions as well. Because I will tell you, the system's complex. Everything that we do is very complicated, and it is very much not police work like we thought we were going to get into. So a lot of times people have questions about what to do. I believe that is it.
Well, that's incredible what you guys are doing. And I think you are ahead of the curve without question. You know, I don't want to jump in line here, but does anybody have any questions or any feedback or anything that they'd like some more information about?
I do have a few comments, and Chair, you can go ahead and I can follow up and might be in the same lines. I'll just jump in. Is that okay?
Yeah, go ahead. Yeah, absolutely.
Okay. On the mental health calls, I assume a great deal of them are mixed in with drug problems as well. Is that an intermixed problem where you have 2 issues going on at once?
Yes, co-occurring issues that we do have to manage. There's a lot. I will tell you that is not, I wouldn't say it's the majority of mental health calls. A lot of it is really just straight mental health issues. Obviously, our homeless population probably is a little bit higher in that regards, that we're managing 2 at one. But what I will say, and I always tell people, is the training that we receive is not going to really tell us which it is. So we treat the person the same way, either way. So we provide kind of wraparound services because we don't know. I mean, sometimes obviously we do know there's evidence of drug behavior or whatnot, but a lot of times we really don't know. So what we stopped doing was training to figure out what it was, and we started training to manage a crisis and just a crisis in general.
Excellent, excellent. Is when individuals are dropped at CBI, is there ever an issue around health insurance or how the care is paid for?
No, there isn't. And I don't want to step on CBI's toes, but I will tell you that through access down through Mercy Care, this is funded through the crisis system. The Maricopa County crisis system is the most well-funded crisis system in the country, and the entire country. And the drop-offs, the crisis teams, the crisis line, all of that are paid out of a giant block of funding. So the person's insurance is not billed, they are not billed later. None of that comes up. Everything that we do is handled through this block funding. So that's an amazing part of it, is it's actually already paid for.
Excellent. So everybody's able to maximize the care that they can get beyond initial crisis.
And CBI, I doubt they'll talk about this, but CBI is also really good about getting people into services. So if they don't have insurance before they're released, they have people that work there that actually specialize in signing them up for access or whatnot.
Okay, great. I'm very proud of the work that you do and certainly to lead on any next steps as we evolve and transform, learn more, and be able to be more of service to those in crisis. Thank you.
I always appreciate your support.
Vice Mayor, Chair, we do have quorum now.
Okay, thank you. Well, Officer Stamps, we're grateful for that presentation. You're right. And you just talk about data, right? And the data is proving out of what looks like a best-in-class service for the community. And so hopefully, Kelly, we can ensure that other cities, I'm sure our city managers are aware of this, and they're looking for ways to implement that as well. How many cities did you say are already taking part in this, Officer Stamps?
So what I will say is that every agency has a CIT coordinator. So there's always somebody embedded with the department that can answer questions. Peoria has a 2-person team that they're called I don't remember what they're called, but they are specialized in behavioral health and substance use and homelessness. Scottsdale just got their own team, although Scottsdale, I don't know if there's anybody for Scottsdale, but Scottsdale originally had the gold standard of 7 crisis counselors attached to their PD 24/7. So and they've been around longer than I've been alive. So they started doing this a long time ago, but they now have a police-based crisis response. And I do know Chandler and Gilbert are looking at it. Phoenix obviously has a crisis intervention team as well. Those are all I can think of for Maricopa County, but I will say that all of our agencies, all of your cities are doing something. It just might be still a patrol-based response.
Okay, thank you. Any other questions? Okay, let's move
Feel free to
back.
share my email if anybody has any further questions. Sorry.
Oh yeah, leave it in the chat. That'd be great. I'm sure there's some folks that might want to share this with the department or with their city manager or somebody else on their team. So thank you. Thank you very much.
Thank you very much.
Vice Chair, because of open meeting law during the pandemic, chat is not an option at the moment, but we will share our speakers' email addresses with the full council.
Thank you, Kelly. I appreciate that. Why don't we go ahead and get kicked off here and take roll, and we'll get the minutes approved, and we'll do a call to the audience, and we'll move through the agenda as scheduled. Does that sound okay? All right, perfect. You want to take roll, Kelly?
Thank you, Chair. Mr. Councilmember Wally Campbell.
Present.
Councilmember Ali Klein.
Here.
Councilmember Tina Condi.
Here.
Vice Mayor Monica Dorsey.
Here.
Vice Mayor Jen Duff.
Here.
Supervisor Steve Gallardo. Vice Mayor Betty Janik.
Here.
Councilmember Joel Navarro.
Here.
Councilmember Bill Patana. Councilmember Amy Yentes. And Chair Mark Stewart.
I am here.
Thank you.
Thank you.
Are there any other members participating who were not mentioned or called? Thank you.
Okay, well, let's move to item number 2 on the agenda, call to the audience. It's an opportunity for public comment on the agenda that was provided ahead of the meeting. And as I noted, or as Kelly and I talked before, there are no comments received. Anyone on the floor? Okay. Are there any questions before we entertain a motion to approve the meeting minutes from last month? Okay, hearing none, is there a motion to approve, please?
I'll make a motion to approve the September 23rd, 2021 minutes.
Joel Navarro seconds.
We have a motion from Vice Chair Duff for approval and a second by Councilmember Joel Navarro. All those in favor?
Aye.
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 The motion passes without dissent. And we'll move on. We just heard from Officer Stamps about the crisis intervention team model. Thank you again, Officer. And we'll move on to item number 5, which is community bridges outreach model. This part of the agenda will be presented by Eric Alfrey, the Director of Integrated Care from Community Bridges. Mr. Alfrey will present on the model for helping individuals experiencing behavioral health crises in the service. This item is on the agenda for information and discussion. Mr. Alfrey, the floor is yours. Thank you.
Thank you so much. I want to start off by thanking you all for having us and giving us the chance to speak on Community Bridges services, and also wanted to thank Detective Stamps for her presentation earlier. Fantastic work. We are at CBI extremely proud of our partnerships, and Detective Stamps and Mesa PD is a very strong partner and always has been with Community Bridges. I'm glad to hear that our CPEC location, as well as all of our other continuum of services that we'll get into, has been a strong partner for them as well. So Community Bridges is a very large agency. We have a large continuum of services, and so it's large geographically and also extremely large in terms of the diversity of services that we provide. This presentation, I would really like to get into talking about different levels of care and kind of what's involved in those different levels of care. But what I would like to do first is I'd like to introduce Jeremy Huntoon, who has joined me here. Jeremy is one of our partners at CBI. He's one of our leaders, and he comes from the peer model. Okay, the peer model is it's a best practice for one. It's an evidence-based practice out there, and the peer model is at the very core of Community Bridges and what we do. So Jeremy is going to take a few minutes and kind of talk about peer model, talking about street outreach and some of the aspects of who our peers are, what they do. And then when Jeremy's done, I'll talk a little bit more about our continuum of services, and then we'll open up the floor for questions. So Jeremy Huntoon.
Yes, good morning. And just to reiterate, thank you guys for having us here today. If we can just move on to the next slide. So of course, with Community Bridges, we wanted to share our mission and our purpose, which is to maintain the dignity of human life and to be an agent of positive change in our community. So we really drive that into our frontline staff and of course across the entirety of our organization. But as we step out into the community in that outreach model, this is definitely something that we want to bring with us and have on the forefront of our minds. We can go to the next slide. So I wanted to talk to you guys a little bit about the importance of outreach. And so what we're looking at right now is the homeless outreach viewer, which is we work on that in tandem with the MAG or Maricopa Association of Governments. And what this has allowed us to do is, as we go out into the community and we engage with individuals that are experiencing homelessness and residing in places not meant for habitation, we are able to enter the latitude and longitude for the area of those encounters. And then that helps us, of course, to make some more of those more informed or data-driven decisions when targeting particular areas to support the members that are residing in those places and our communities. And so what you're looking at here is, each dot on this map represents those individuals who typically aren't coming to our crisis facilities. They aren't presenting themselves for services. So the importance of outreach, it allows us to step out and bring those services to them, and then work with other entities or refer internally to our own resources to start driving to a place where we're bringing that much needed integrated healthcare model, as well as housing services to those individuals to support them in ending their homelessness. So the red dots represent individuals that the system has identified as being chronically homeless. And then the blue dots represent those individuals that have yet to meet that definition or may not ever meet that definition due to particular interventions that are available. Can we go to the next slide? And so that brings us to a place where we want to identify those barriers and work with those individuals and really bringing that down, right? So offering, again, that integrated care model and shelter services or whatever is most appropriate for that individual and their situation. If we can go to the next slide. And so some of the, of course, common barriers that we see out there when coming across individuals experiencing homelessness, of course, it's that full gamut, right? The social, the economic, the mental illness and substance abuse, but also that need to survive. So one thing that we're really big on in training is how to build that rapport with individuals. So as we step out into those places not meant for habitation, that's for the members that are residing there within our community, we need to be mindful of the fact on just some basic human nature, which is, we're not always willing to trust the first time out. I'm not always willing to engage in certain services as they're presented to me. So it's very important that we continue to go out there and practice that assertive engagement and respectfully give them continued opportunities to engage with us in the variety of services and an outreach component, and how we fuse that with some of the services that Eric's going to be talking to you about in the next couple of slides. If we can go to the next one, please. And so when we, again, when we develop that with peers and identify a peer, it's a community bridges peer support specialist is an individual who is in recovery for 1 year or more, either from alcohol, substance abuse, and they have that solid foundation that's built in that recovery process. And then, of course, we want to be mindful of identifying individuals or hiring those individuals that are going to be able to step out into that field and with that ability to relate to homelessness and have that understanding. And so when we have what we refer to, that's down at the bottom bullet point, the Navigator 90-10 model. So I'm not going to have high expectations for that individual within our initial case planning process. I'm going to go ahead and take on 90% of that workload. I'm going to offer my time to really build that foundation for them and get them to a place where, we can start working on that self-efficacy or sufficiency, but that's something that takes time. And so that wheelhouse, it's really identifying, what we're good at internally, and then what our other community partners, what's their wheelhouse as far as job development, and really getting them attached to some of those incomes. And then, of course, looking at natural supports for that individual and encouraging them to re-engage with any family or friends or community supports that they already have naturally in place. And then if we can go to the next slide. So some of the outreach programs that we have as listed here, starting with our PATH program, that is a regional response to homelessness for the entirety of Maricopa County. That is, it's a SAMHSA grant with some state funding, state matching dollars on that. So we are able to cover, the entirety of Maricopa County, and that funds 15 navigators to go out and provide that outreach service. And they're specifically looking for individuals that are experiencing homelessness due to a serious mental illness, whether that's a current designation that they may have, or based off of our assessment, we feel that that's a criteria that they may be eligible for. And so we bring our clinicians into that process to provide that SMI evaluation, along with getting them connected with the ongoing behavioral health care. So, of course, 15 navigators for the entirety of Maricopa County. Sometimes, there are some capacity issues that fall into that. So building those relationships with some of our municipal partners is what's brought us into other outreach programs such as Phoenix Cares, Glendale, Mesa, Scottsdale, where they have then funded or contracted with us to provide those outreach services specific to that municipality. And then the Phoenix Cares program has opened it up to where citizens are able to file reports on encampments that are present. And then we then go out and work with those individuals to bridge them over into services. And then we have our crisis response teams as well that, we're very first responder focused. So we provide that education to them to be able to make those referrals to us. And then we go out real time into the community and get those individuals over to our crisis facilities. Next slide, please. And then, of course, working with the criminal justice system. So, we have several projects that we have one project that is in the Maricopa County jail system, and we get those referrals for individuals that are experiencing homelessness and have repeated offenses. Then while incarcerated, we're able to go in and provide some further discharge planning along with the correctional health staff during their incarceration. So that way, upon their release, we meet them at the gate and get them connected with those shelter services or substance abuse treatment and ensure that they have that ongoing behavioral health care as needed. And we're also located in City of Mesa courts, where we work with that courtroom staff on individuals that have been cited in for misdemeanor offenses as related to their homelessness. So then we work with that individual, we enroll them into that program and continue to design case plans, which will then lead to those charges being dismissed once they are successful with the courtroom directives. And then as well as collaborating with various probation officers. We're specifically contracted with the Maricopa County Adult Probation Department for their drug court. So we work with the probation officers to identify individuals that are within that drug court system that have housing instability. And then we enroll them into that project and then work to get them connected with other ongoing resources that will improve their likelihood for graduation within that drug court model, which is something that we've been very successful with. And then, of course, working with other officers and various police precincts in the field, like Amanda Stamps and other areas throughout the valley, to take those referrals to go out and provide that outreach and service delivery to individuals that are residing within places not meant for habitation. And then if we can go to the next slide, please. And that is Mr. Alfrey.
Thanks, Jeremy. Yeah, and I want to echo the piece that Jeremy had mentioned about the peer model and talking about who the peers are. The peer model is it's tried and true, and honestly, seeing it firsthand is pretty fantastic. We do peer certification internally. We train our peers to really utilize their lived experience to go out and do outreach and all the things that they do, including working in our clinics, doing street outreach, doing jail in-reach, all of the above, and utilizing that shared experience and having their stories. It hits a little bit differently with folks to sit and level with somebody who's been there in the past and has that shared experience. And the research shows it that it's a successful engagement model. So moving then from sort of how we engage folks out in the community to what our services look like internally, one of the things at CBI that everybody who works here hears on a daily basis is the term "no wrong door." Detective Stamps had mentioned some of our funding and some of our grants within our crisis and inpatient programming. That's all extremely true. One of the hugest advantages of community bridges is its diversity, and I say diversity and mean it on multiple levels. Okay, so we have I've worked in multiple places in behavioral health and healthcare in general. I've never worked somewhere that was as flexible as CBI is and as aggressive in attaining an extremely diverse profile of funding. We utilize grants, we utilize name and insurance, we take it. There's really, truly no wrong door for folks getting into our services. Somebody walks into one of our locations, that we get them where they need to be, and we get them what they need. Also important in our diversity services are locations. We have multiple locations all around the state. There are actually some others that aren't even mentioned on here, but these are the larger locations across the state. We do find that quite a bit of our population moves around. So we have, even just speaking outpatient only, we have 5 different locations in Maricopa County. I think that we have something around 43 or 44 locations around the state that provide different services that are tailored to those particular communities. We find that tailoring those services to the needs in those communities is fantastic, and is of course contingent upon our partnerships with the various entities, PD, probation, all the above in those various communities. So if I can get the next slide, please. So in terms of what services we have available around, we talk about levels of care. We talk about the different sort of things that are available to match the need as someone comes in. I found the discussion interesting earlier about that sort of triage portion that happens. Is this somebody coming in for substance use disordered needs versus somebody coming in for mental health? I will say that triaging is extremely difficult, and also extremely, how do I say this, nuanced, if you will. I will say this, and some might call this a bold statement, but there's not a person coming in with serious substance use issues who doesn't also have serious mental health issues as well, right? And when I say mental health issues, I mean that in the larger sense, okay? So because of that, I know that a lot of folks think community bridges and they think substance use treatment, right? We find best practice, and national research, of course, supports this. National best practice for treatment involves what we call integrated care, and I'll get to our integrated care clinics in a moment. So down that continuum a bit, though, right? We find folks in crisis. Somebody goes out. Our navigators go out. We have street outreach. Someone calls in. We have that triage piece. Some folks are in a place where they are extremely acute with substance use. Maybe they need inpatient medical detox. Some folks maybe have extremely acute mental health issues. Maybe they need inpatient mental health. We have all of that available in various locations around the state, right? But I will say, folks coming into crisis and detox, hugely important, huge piece of what we do, but we haven't actually finished our job unless we translate, unless those services translate from that crisis to ongoing services, okay? And if I could grab the next slide. All right, so within this full continuum of care, we've got our ongoing goals there, right? There's the crisis piece, the initial continuum of services, and then your ongoing goals, right? We have that full continuum of outpatient services, right? Your MAT outpatient, all right, PCMH, which stands for patient-centered medical home, right? Housing, navigation, and really getting folks back on their feet so that they, in a way that they stay on their feet, right? MAT services, in case you don't know, is medication-assisted treatment. The most typical being methadone services. We have, of course, a variety of MAT services available that, to match the particular patient's need. Of course, mental health rehabilitation as well. The continuum of services within our integrated care clinics, if you can go to the next slide, please. Next slide, please. Okay, really kind of falls within this, right? We have, of course, our physical health. All of our PCMH clinics are fully functional. We have PCP services available, so any physical health needs, right? And then we have the mental health needs, okay, which of course includes case planning, case management, therapy, psychiatry, the whole gamut of mental health services, and of course the peer support that Jeremy had mentioned. We find that bridging these together in one integrated care environment really provides folks with that one-stop shop where they can get these services together that continuity of care happens, that case planning happens together, and really is best case scenario for outcomes in the future. Next slide, please. So like I said, our mental health, psychiatric care available 24/7. We, of course, our outpatient clinics are business hours, but our crisis centers supplement, right? Substance abuse services, general mental health, and counseling. Next slide, please. Yep, and I mentioned our physical health, primary care. Of course, to access our physical health services, folks do not need to be paneled with us as their PCP. Anyone can come in and get physical health. Of course, immunization, annual wellness. Next slide, please. And the peer support, right? And one thing about peer support too that I need to mention is that, of course, that front door with peer support is absolutely huge, that engagement portion of things. We do, however, utilize our peer supports for ongoing support in terms of, everyone in treatment sometimes still needs someone to talk to. Maybe someone relapses, maybe someone, has an issue with their housing. Peer supports are integrated into every piece of our service, every step of the way. Next slide, please. I did want to mention Center for Hope. Amongst our continuum of services in Maricopa County in particular, we do have Center for Hope, which is our gender-specific housing program in Mesa. I think we have 24 beds at Center for Hope, which is a pretty amazing facility. 24 beds available. It's long-term transitional housing for women who are homeless, pregnant, or postpartum with substance use issues. It's basically live-in integrated care support for women with substance use issues who are in recovery. Amazing service, huge part of our continuum of service. Next, please. And one of the newer services available at CBI that has been developed in the last several years is that we are now serving adolescents at community bridges. And that historically, CBI has been adult focused in our services, but we have opened up our outpatient services for adolescents in the last 3 years. That's actually my specialty division that I work on. We're working on a full continuum of care, but we have been really at the forefront of adolescent substance use treatment. We were the first contracted provider in Maricopa County, I think almost Arizona, to do medication-assisted treatment services with the full continuum of care for adolescents. All right, next slide, please. Okay, so that kind of wraps up what we wanted to cover. I think we might have gone a little long, so I apologize if we did, but I'm hoping that gives you all kind of an overview of CBI services, and I would open up the floor and hand it back to Kelly for any questions or whatever we need.
Thank you, Mr. Alfrey. Great presentation, and the work that you're doing is extremely important, especially as we talked earlier, about crisis intervention and sort of this just this macro approach to trying to help as many people as we can. So this is certainly a facet of that, and so grateful for the presentation and the work. Do we have any questions for Mr. Alfrey or Jeremy?
I have a couple of quick, I see Joel. Joel, were you about to go?
No, go first. I'll go after you.
Oh, okay. Adolescents, is that 18 and under?
Yeah, it is. So the rule of thumb that's essentially my rule of thumb, because I'm over the adolescent programming, is that if someone is old enough to abuse substances, they're old enough to be part of our adolescent treatment, substance use treatment program. So we scarily and unfortunately have had some 11 and 12-year-olds who have been abusing substances that we've worked with. But yeah, that's 11 and 12 all the way up to 18. But that being said, one of the other pieces of our adolescent program that I really am proud of is that our folks can keep the same treatment team after they turn 18. So somebody can start services with us at 16 or 17, and they wouldn't know the difference in terms of keeping the same counselor, the same psych, the same doctor post turning 18. We find that continuity of care extremely important for those transition aged youth.
That's wonderful. And how is fentanyl affecting the services you're able to provide? And is there anything that we as public officials can help in that endeavor with any federal funding or opportunities that we have? Because I'm really concerned about the explosion of how it's affecting substance abuse.
I think explosion is the correct word. It is a bomb that has been dropped on our children, and it is horrific out there. The number of fentanyl referrals that we've seen has skyrocketed in the past 3-4 years, in particular with our adolescent population. It's being infused into other drugs everywhere. Some kids know what they're doing, some kids don't. It is really difficult. And one other portion of CBI services, and CBI is huge, that I hadn't mentioned, that I think probably would come into play here is our prevention program. We do have school outreach where we have counselors placed in the schools, but we also have a prevention team who goes and does substance use education with parents, teachers, schools, teens, and adolescents, to really kind of educate folks on the dangers. Obviously, it's not dare. We utilize curriculum that actually is evidence-based and has been shown to be effective in working with folks. My 2 cents, ounce of prevention, gets you there.
Great, thank you very much.
Absolutely.
Councilmember Navarro.
Yeah, thank you. First off, great presentation, great information. Obviously, this is a great need across the region, the coordination between CBI and our public safety, between PD and fire, just human services throughout the cities. Just having that partnership is huge. Obviously, with the questions we've just heard right now, and what more can we do? I think it kind of leads into my next question for the group, which I can hold on to it if it's not the appropriate place. But I think as a region, and then Mark, just let me know if we need to table it for a little bit later. But I think for the region, with all these partnerships like CBI, the cities are going to have to start stepping up. I know we talk about things that, are good practices that we can implement, but I think there's a conversation about, as a region, how do we partner together when we talk about homelessness? And one of the topics may be, sheltering. How does that look throughout each city as we go forward? And what can we do to start moving the ball? Because too long, and I've talked to a council member in Mesa, it's just like we are talking, but we're not making action. And just kind of one of those things. What is this a discussion for later? To talk more about it, Mark, I'll leave it up to you. But thank you for the presentation, and I'd just like to push this thing forward.
I hear you a lot clearer. Matter of fact, it's one of the reasons that I think most of us are involved in this panel, right? And part of the committee is to try to move the ball down the field and see some progress. And I think Wally, you can attest to this, is that we've talked about this before. It's like, where do we move the ball? We've got our city managers working together. We've got this committee that's working. We've got incredible presenters, non-for-profits that are working on this at all angles, and they're I don't want to say they're silent, because they're not, but they're working diligently to get some of this stuff done. And it's just an overwhelming challenge with housing crisis, the pricing, inflation, everything you want to add to it. It's becoming a real challenge. And so moving the ball is literally going to take, grabbing the elephant by the ear and taking a bite. And I think that's what some of these programs are doing. But I couldn't agree with you more, Joel. And maybe that means that this committee needs to send a representative, and I'll volunteer to do that, to one of these city manager meetings, and express that, you know, we need to see some action at the city level, and as elected officials, that's our job, is to push our cities, and to push the folks that are tasked with these projects to do that more. So I'm glad you brought it up. Anybody else want to add to that?
Yes.
Councilmember Conde?
Thank you, Mark.
Vice Mayor? Yes.
Thank you for the presentation. So I am a council member for Avondale. So we have a CBI here in Avondale. And we do partner with you guys. You guys do outreach in our community. A couple questions that I had is in regards to the length of stay. People can stay at CBI. And the second question I have, are people released with no place to go? Because oftentimes our constituents have concerns with the clients kind of just staying and kind of gathering in those areas.
Yeah, thank you, Councilwoman. That's a fantastic question. Now, I will say that when you talk about Avondale, our Avondale clinic is actually pretty diverse and has different levels of care within that facility. So we have our crisis, we also have our transition point, right? As well as our outpatient services, all in Avondale, okay? So folks who are coming into crisis, the length of stay there, it's generally a 23-hour bed, right? So they're gonna be in and out, right? And there's, you know, that's a licensing funding sort of thing. Our transition point is actually technically residential. So someone can stay at our transition point for, I think, up to 4 weeks or something along those lines. And then our outpatient clinic is outpatient, right? Like you would think of any other outpatient clinic. The best case scenario, and there are of course a million variables that go into this, but the best case scenario is that those different levels of care are supporting each other, right? We do our absolute best to not turn folks back out on the street who have nowhere to go. We do, you know, Jeremy had mentioned housing navigators. That's a huge piece of what we do. We have housing navigators. We have loads of grants and resources available to folks. That being said, there are finite resources for one, as well as we, you know, I don't know how to put this, but there's leading a horse to water. You know, some folks do refuse help, you know, and
Yeah.
you can't hold someone because they're homeless. You know, they're going to go back out in the community, and we of course will work with folks as best we can. Another level of care that we do have for folks who have those higher level of acuity is we do seriously mentally ill services as well. You know, and we will get folks evaluated for higher level of care and do everything that we can. So and this is a long answer, not a short answer, but the long answer is that it depends on the situation, but we do everything that we can to make sure that folks have all the resources that we're able to give them before going back out into the community.
Great. Yeah, because just based on the chart that Jeremy had shared with those clusters of non-chronically homeless and chronically, you know, I see a large cluster in our city. The cluster primarily being the non-chronically homeless. You know, we do provide great resources. You know, we have the iHelp program. And it's going to take everybody, you know, to jump on board and really help. It'll never be, we can't get rid of the homeless population, but we can definitely kind of case manage. And I think that it's critical. The outreach is critical, but we have to have that case management piece along with it. Yeah. And, you know, we're always reaching out to our faith-based partners, of course, our elected officials, and just other nonprofit organizations. But like Vice Mayor Duff had said, it's a fentanyl explosion. Absolutely. And it's scary because it's our youth that are using these drugs because they can get them fairly inexpensive and they're highly addictive. So, you know, back in the day before COVID, we were worried about the silver tsunami, right? We're talking about that population being homeless. Now it's just a tsunami in general. You know, we have the fentanyl, you know, people being evicted. So I just wanted to say thank you guys for the work that you do. I know it's not easy, but it's necessary. I I just look forward to hearing more. And as a city, I know that we're looking to develop different things, not reinvent the wheel, but I love what Mesa's doing. And I hope that our staff and our PD has been reaching out to kind of learn more and implement some of those things in our city and in the West Valley. So you're right, everybody needs to step up and help kind of manage those issues. Thank you.
Yeah, no, absolutely. Thank you. The city of Avondale has always been a very, we've always had a strong partnership with the city of Avondale, and I'm very proud of that.
Good, thank you.
Thank you. In the interest of time, I want to move to item 6. If there's anything pressing, please share that with Kelly, and we will get back to you, or have Eric get back to you as well. So item number 6 on the agenda will be presented by Kelly Williams, the Director of Human Services. This item is on the agenda for information and discussion. And please go ahead, Kelly. Thank you.
Chair and members of the committee, thank you for your time this morning. I am bringing to you some information about the upcoming decisions that will be brought to you in January regarding the Social Services Block Grant. The Human Services Technical Committee convened a special work group to review previous spending from 2021 on these dollars across our region. It is anticipated that we will receive about $3.6 million to be allocated into different categories to help the region's most vulnerable. The recommendations I have to share with you today, which I will also provide in writing and send out with the minutes, include recognition that seniors are among the most vulnerable in our community due to the pandemic, recognition of wait lists for senior home care services, increased funding for home care services, including personal care, housekeeping, and nursing services for seniors to help keep them living safely in their homes, with an increase of $60,000. Recognition that affordable housing, especially for seniors, is very limited. Increased funding for housing support services to seniors to help them locate and maintain housing, with an additional $250,000 allocated. Recognition for the need of stability in funding for services for those experiencing homelessness at large, including emergency shelter, crisis shelter, and DV shelters. Support of the MAG Regional Homeless Plan by keeping homelessness funding consistent from previous years. And recognition that case management for basic needs services can be critical to support the well-being of families. I realize that is a lengthy list of bullet points, but I will send you on the dollar amounts that were reviewed by the work group, including their recommendations, and they will be presenting, likely it will be our chair, Director of Human Services for Maricopa County, Jacqueline Edwards, at the January meeting of your committee to present these recommendations to you for a vote. We will also have an individual from DES who manages these funds in partnership with MAG present at that meeting as well. At this time, I'm open to any questions from the chair or the members of the committee.
Okay, hearing none, I think we'll move on to item number 7. And Joel, this might be a good opportunity for you here, but is there any request by a member for a future agenda item, any topics or issues that would be of interest to this committee that we'd like to listen to and possibly take action on?
Mark, having one, obviously what I just talked about, I don't know if something can be agendized on, I'm just kind of spitballing, through MAG. How do we, from this committee, push up to the regular MAG meeting the options or ideas of working together across city to city to city on providing, what are tentative best locations for sheltering areas, or an area within each city to be able to shelter homelessness. Deeper dive, maybe this is something that we work with, or maybe have a brief presentation on some options or ideas, but then to bring back to our cities to try to find tentative solutions that we can present to this group, but then ultimately, I think through MAG and the mayors in the region of, hey, these, might be the areas of swell, kind of like heat map type of thing, and where practically you could implement some sort of sheltering system within strategic locations within those areas that don't encroach on housing and neighborhoods and things like that. But maybe that's an idea to gather that information, bring it back to this group, push it on up, and then try to figure out solutions of funding across the region to start implementing these programs city by city. Just a thought, and I'll leave it at that.
No, it's a great thought. And Kelly, why don't you and I circle up and see what something like that might sound like and look like, and just see what the policy and process would be for delving into that a little bit deeper.
Sure, Chair and members of the committee, we do have quite a bit of the data that Councilmember Navarro is discussing available in our regional homeless plan that will come before the regional council for a vote on December 8th, which is a regional plan to address homelessness in many ways, including emergency shelter, temporary and permanent housing for different vulnerable populations. We do anticipate having Deputy Director Amy St. Peter present at the January meeting of this committee to discuss the plan, the regional plan, including many of those details. And at that time, we could definitely take further questions or further data points as requested and present them to the committee in future meetings.
So it sounds like it's already on the agenda, Joel, in part and parcel. So that's great. It's as usual. You're a lot in front of this, and I remember our discussions a few months ago about this. So thank you, Kelly. Joel, I think thank you for bringing that up, and I think hopefully the December 8th meeting will cover some of that, and if it doesn't, that'll be a good opportunity to then broach the subject and make sure that we're covering all the gaps.
Perfect. I feel like we're moving the ball already. Look at this. We already made advancements.
Anyone? Okay. Let's move to item number 8, comments from the committee. Are there any comments or announcements by committee members? Anything that you'd like to share that we need to share with our cities? Any best practices, anything like that? Okay. Kelly, anything from you in your office?
Here, the only thing I would add for members of the committee is that the 2022 meeting dates will be sent to both the vice chair and the chair for review within the next week. And those dates will then, once approved by the vice chair and chair, will be sent on to the committee at large. They are, of course, tentative. If things come up and we need to reschedule, we can always do that. But we will try to get you those dates and events on your calendars as quickly as possible for your planning for the next year. And we continue to sincerely appreciate your participation in this conversation. It is vital to our work here at MAG, and we just really appreciate all of you coming to these meetings and your active involvement.
Kelly, thank you. And thanks to everyone on the call, especially our presenters. It's very important that we understand and we have this information. On behalf of Vice Mayor Duff and myself, we will call for adjournment unless there's any last minute thoughts or comments. Okay. This meeting is adjourned. Thank you.
Thank you all.